Of all of the studies we had, this was one of the most impactful for me because it really showed something that we believed all along, is that we're under detecting PFO. And in those cases, the screening can be brought up to essentially 100%, TE being the gold standard and TCD being highly sensitive. With both of those strategies, we were able to show a significant impact in detecting patients who would benefit from PFO treatment and closure, and that leading to reduced risk of stroke. And in a cohort of 1,000 patients, that meant over 60 patients had a reduced risk of stroke if they were properly detected with either TCD or TE. The key takeaway in this study was fairly simple. For every 4 patients we screened with a proper diagnostic strategy, you'd find 1 more patient that would be appropriate for closure, and to shift our strategies to adopt that, to use TCD and TEE in patients in whom we suspect are at risk of PFO-related stroke, and not to necessarily rely on a negative transthoracic echo. One of the things that surprised me about this paper was the impact of cost savings. We often think about improving diagnostics as being something that will lead to more procedures and more costs, but it actually turns out that if you properly detect and treat a patient, you're actually saving money. You're saving money in terms of reducing their risk of a second admission for stroke, and you're saving money in terms of not leading to the disability of a second stroke. So not only was putting more effort in on the front end to detect it beneficial for their health, it was beneficial for their health economics. This paper's impacted our clinical practice by really underlining what we already knew. We have PFO diagnostic guidelines that stress the importance of screening with TCD or TEE. And this paper has shown that implementing those guidelines, actually using them in our practice, will yield the proper diagnosis in more patients and lead to the proper pathway and workup and treatment and prevention.